Hello, and welcome to the Dornsife School of Public Health's 2020 Public Health Immersion program. My name is Caroline Boyles, and I'm the Director of Student Placement and Partnership Development at Dornsife. I'm joined by Jordan Wood, the Practice Office Assistant and an undergraduate senior at Dornsife. Today, you'll hear from some of our faculty and alumni about how they apply public health research and practice in contributing to the well-being of local, regional, and global communities. Additionally, this module will feature examples of how Dornsife students have the opportunity to apply classroom teaching towards making a difference in the world of public health.
Welcome to Module 3, Infectious Disease. In this module, you'll hear from faculty member Dr. Michael Levasseur about his work in the field and MPH alumni Alexis Reynolds about her experience at Dornsife.
Hello and welcome to this presentation for the DSPH Immersion program for the class of 2020-2021. I'm Professor Michael Levasseur, and I'm going to talk to you about R0 and provide a friendly guide to ending an epidemic. Hello, I'm Dr. Michael Levasseur, and I'm an assistant professor of epidemiology and biostatistics here at the Dornsife School of Public Health. My research interests include infectious disease epidemiology, gender and sexual minority health disparities, data science, programming, big data analytics, and bioethics. A lot of the courses I teach here are around statistical programming, specifically in the SAS language, and I look forward to working with you in future courses. In the past year, there have been a lot of conversations around R0, especially in the media. R0 is an epidemiologic concept that attempts to capture how infectious an agent is. And at its core, R0 provides an estimate of the average number of susceptible individuals an average infected individual will go on to infect. It's important to note that those averages represent the average or typical person. Any R0 value above 1 implies that there is epidemic growth, and any R0 value below 1 implies that the agent is heading towards elimination. Any R0 at or around 1 implies that the agent is endemic, meaning that every individual is going to pass it on to one other individual. RT is an epidemiologic concept that attempts to capture how infectious an agent is at any given moment in time. In this graph here on the left, you can see a representation of RT from the COVID-19 data from a project that I've been working on with a fellow data scientist of mine. Starting over here in March on the left side of the graph, you can see that the RT was a lot higher and even went over the graph, but then throughout April and June, it fell below 1 before picking back up again in June and July. So RT is a way of tracking how infectious the agent is at a given moment. And it doesn't really change how infectious the agent is, but it's the impact of a lot of the interventions that we place on it from a public health standpoint, which we'll get into during the course of this presentation. There are multiple methods for calculating R0 and RT. One of the best methods that we have is through contact tracing, where we can get both the secondary attack rate and the effective reproductive rate. The secondary attack rate is the percent of exposed individuals who go on to become infected. During contact tracing, people who are infected are contacted by people from the Department of Health and asked about all of the contacts they've had during a certain period of time. And they report those contacts to the Department of Health, and then the Department of Health tracks those contacts to find out whether or not they have become infected, and also to encourage them to self-isolate and get tested and monitor their symptoms. The effective reproductive rate is the average of the number of individuals an infectious person went on to infect. And so you can calculate this by taking all of the cases that you've identified and find out how many of those contacts that they've reported go on to become infected, and then taking the average of those numbers. But more often than not, especially during the beginning of an epidemic when we don't have all of the information, R0 is calculated based on very complicated statistical models. We're not going to go into the details about what goes into these models, but they're based on certain assumptions about the agent, and we can use multiple data sources to determine that RT, including the ratio of hospitalizations to deaths, the rate of new cases, the percent positivity, and other surveillance techniques that we can use to pull information in about human behavior. And so these modeling efforts are really a best guess, and you've probably seen in the news a lot of models being covered. And when it comes to these models, each one of them is going to be incorrect. None of them is going to perfectly model what's actually happening in nature. So really taking a large number of these models and seeing where they converge and where they differ is where you're going to get information about what's actually happening. So what is R made up of? At its core, R naught is the product of three terms that we can think about: C, P, and D. C is the number of susceptible contacts the average person has. That's the number of people who are susceptible to becoming infected. The P is the per contact probability of infection. So for each individual that you come into contact with, what is the likelihood that they will become infected? And then D is the duration of infectiousness. How long is someone going to be infectious for? If you multiply these three products together, you can come up with the R naught value. In the world of infectious disease epidemiology, the letters C, P, and D spell public health, because we can develop interventions against each of these different aspects of an infectious agent. So let's take, for example, C. This really wonderful paper that was published in 2008 by Masong and colleagues, titled "Social Contacts and Missing Patterns Relevant to the Spread of Infectious Diseases," has been a paper that I've looked at quite a bit over the past couple of months. In short, they basically took a bunch of participants from different ages throughout Europe, and they asked them to count the number of people that they had contact with over the course of a certain number of days. And so you can see, if you look by age, you'd see that children aged 0 to 4 had an average number of 10 contacts per day. And then those who were 5 to 9 had about 14. And then those between 10 and 14 and 15, 19 had about 18 or 17 contacts. And the number of contacts that you have per day sort of decreases as you age. You can see that males and females had about a similar number of contacts per day, about 13 and a half. These changed based on household size in a monotonic relationship, which isn't necessarily surprising. So for each additional person that lives in your household, you have about one more person that you have contact per day. There was some weekly seasonality where there were more people that you had contact with during the weekday and fewer on the weekend. And then these also differed quite a bit by country, which shows some sort of cultural aspects of the number of contacts people have per day. And so this can serve as sort of a basis for how we understand how many people we have close contact with on a given day, to sort of, really think about how impactful some of the public health measures that impact this C parameter can be in preventing disease. So they go ahead and they further break down these contacts by whether or not it's a physical contact or a non-physical contact, and the duration of time. That's this A figure here, the duration of time that they have for these contacts. So when the amount of contact is fewer than 5 minutes, it's more likely that it's going to be a non-physical interaction. But as time that you spend with that individual increases, it's more likely to be some sort of physical contact, whether that be a hug or a handshake, a pat on the back, whatever. There are also differences based on the venue and the location where you are encountering these people, how frequently you see these people. If it's your first time, it's less likely to be a physical interaction. If you see this person daily, it's more likely to be intimate and physical. And then they've also broken it down further by time and duration. And so, again, you can start to get a sense of who are these people that are at risk and what are the factors that make a difference in, for example, a respiratory infection. There was also an interesting relationship between the age of the contacts and the age of the participant. So you see that most people follow this line 1-to-1, so that people of the same age are much more likely to spend time with people of a similar age to them, except for in these groups up here, these little wings to the north and south of this line over here, which indicate when people are raising children. So if you're raising children, you're probably in this 20 to 30 age range, and your children are going to be younger. And so that mixing pattern is different. And this is seen throughout different countries, but it's, each country is slightly different in the way that they have these interactions by age. So there are a number of interventions that we've used aimed at reducing the C parameter to reduce that R naught. And that includes interventions like recommending limiting the number of sex partners. We've had these stay-at-home orders and social distancing with COVID-19, which now we're much more familiar with as a society. Vaccination aims to reduce the number of susceptible individuals, which is part of that C parameter. But also things like paid sick leave, encouraging people to stay home so that they're not contacting people, is reducing C, as well as mandatory quarantine. So you can start to think about different methods that you can use for reducing the spread of infectious diseases by these terms. When we talk about the per contact probability, it really is determined by a mix of both transmission route and the infectious dose. Transmission routes that we typically talk about are fomites, airborne, which can either be droplets or aerosols, or things like blood. Fomites are things that have settled on surfaces that you regularly touch, that you may then get on your hands and then you touch your face, or get it into your mouth if you're not washing your hands before eating. And then the infectious dose is the number of pathogenic particles, which could be virions, prions, spores, or bacteria, that are required to mount an infection. Just having one single virus in your system doesn't necessarily mean that you're going to have an infection. You sort of need to have a certain amount of infectious agent inside of you before an infection will mount. And a lot of that is by chance alone, but it's determined by the relationship between the agent and the body. So if we think about, for example, for HIV, which is one of the things that I study most, you have different routes of transmission, whether you're the receptive partner or the insertive partner when it comes to anal intercourse. For the insertive partner, the per contact probability is further delineated by whether or not the individual is circumcised. Those who are not circumcised tend to have a higher per contact probability of infection. But even further, this changes based on the infectious dose. So those who have an acute infection, like within 30 days of becoming infected, they have a higher risk of transmitting the virus to other people. Whereas those with a chronic infection have a lower chance of infecting other people. And those who are virally suppressed through treatment as prevention or some other agent, these have an even lower per contact probability of infection. And in a lot of cases, these numbers are zero. But for the work that I've done, I consider these to be, slightly risky, which isn't necessarily what we're seeing in the data. But all of these represent different per contact probabilities based on different factors that are associated with both the individual who is infectious and the individual who is at risk or susceptible to becoming infected. So we have a number of interventions that are aimed at reducing this P, including that treatment as prevention that I talked about before. And this is, a lot of things. With HIV, if you are on antiretroviral therapy, you're going to be reducing what we call the viral load. So you have less virus in your system, and so you're reducing that per contact probability, reducing the amount of infectious agent that is inside of you. But this also involves pre-exposure prophylaxis, which are individuals who take a medication to prevent infection, and this will make them less susceptible to becoming infected. There are also barrier methods like condom use or wearing a face mask. Hand hygiene is an excellent method to prevent infection of especially fomite-driven infections. And then there's proper ventilation that we can have, so a number of air exchanges. So this is where our colleagues from the School of Engineering might get involved in conversations with public health, or our colleagues in environmental health and occupational health. All of these can reduce the per contact probability by either focusing on the individual who's at risk or the individual who is infectious. The duration of infectiousness is different for every disease, and it depends on a whole lot of factors. When we're talking about SARS versus COVID-19, the 2003 strain of SARS-CoV-1, had a very long period of infectiousness, whereas we're seeing a much smaller period of infectiousness for COVID-19, which is both good news and bad news, because with SARS-CoV-1, the duration of infectiousness was during the period when people were symptomatic, whereas with SARS-CoV-2, the most infectious periods are when people are least likely to have symptoms, which makes it very difficult to do things like contact tracing. That said, all of these durations of infectiousness that we're seeing on this slide are related to what we call the serial interval. The serial interval is the period between when the infectious person develops symptoms and the infected person gets symptoms. So when you do contact tracing, you could see, oh, well, the infectious person started having symptoms on day 1, and then the person that they went on to infect had started developing symptoms on day 10. And if you just subtract those two numbers, you get a serial interval of 9. So a serial interval that is greater than the incubation period is what we see with most infectious diseases. But you could also have pre-symptomatic transmission, which is what we're seeing with this virus, SARS-CoV-2, COVID-19, where the serial interval is smaller than the incubation period. The incubation period is the period between when you were exposed and when you first developed symptoms. So serial interval is a really wonderful way of understanding some of the transmission dynamics of an infectious agent. And there are fewer interventions that are aimed at reducing this D parameter, but they include test and treat, which are methods of more broadly identifying people in the population as early as possible who are infected to get them on treatment. Treatment as prevention also reduces that duration of infectiousness. But we also have things like vaccination. Even when vaccination isn't perfect at preventing disease, oftentimes, especially with things like influenza, they reduce the amount of illness that you have. They reduce the amount of time that you are infectious. So even a vaccination can be aimed at reducing this D parameter. So, here's the summary of what we can do, and we have a lot of tools in our public health toolkit that have been around for, decades at this point, maybe even centuries, aimed at reducing this spread of disease. And so when we can tackle all of these at the same time, we can really have a huge impact on disease prevention. So for different diseases, some of these parameters are going to be more important. So for example, with HIV, a lot of work is focused more on the per contact probability of infection. So really reducing that, because we have some really great medications that are really effective at reducing viral load. With SARS-CoV-2, we don't really have any medications. We can't really affect the per contact probability of infection right now, nor can we really impact the duration of infectiousness. The greatest tool that we have is focusing on that C parameter and reducing the number of contacts that we have. Now you'll see that we do have wearing face masks as part of P. It's also technically sort of part of C, but a lot of the issues surrounding hand hygiene and wearing face masks involve proper usage of these techniques and getting out and making sure that people understand the importance of using these. And they are going to be effective measures, but I suppose that it's the impact of the C parameter, the social distancing and the stay-at-home orders, and eventually vaccination, that's going to really have the biggest impact on our ability to reduce infections with SARS-CoV-2. And then a little briefly, I wanted to talk about herd immunity, because herd immunity is also built into this conversation about R naught. Herd immunity is the percent of the population that needs to be vaccinated, of the susceptible population that needs to be vaccinated in order to prevent chain transmission, in order to bring that R naught value to 1 or below. And so herd immunity is the fraction of the population for herd immunity is just defined as 1 minus 1 over the R naught value. So we have some estimated R naught values here for a number of infectious diseases, and you can see that the higher the R naught value, the more infectious the agent is, the more people need to be immunized against the agent in order to prevent chain transmission. And we've done a good job with a lot of these infectious diseases: measles, pertussis, rubella, diphtheria, obviously smallpox, polio we've done some good work with, and the mumps. But as vaccination sort of loses, we lose people who aren't vaccinating their children, for example, these numbers start creeping back up, and we can start seeing outbreaks of these diseases again. So vaccination is, still one of the greatest tools that we have in public health. So that's my presentation on R naught. I hope that this is a good primer for some of the thinking that you'll be doing whether you're in environmental health or you're in public health policy, community health and prevention, epidemiology, or biostatistics. These metrics really touch all of the work that we do in public health. And again, I look forward to working with you, and I hope that you have a wonderful time here at Drexel. And if you have any questions, feel free to reach out to me.
Next up, we'll hear from Alexis Reynolds.
Good afternoon. My name is Alexis Reynolds. I am a 2020 Master of Public Health graduate. I majored in epidemiology with a minor in infectious diseases. Right after graduation, I accepted a research data manager position at the Henry Jackson Foundation for Advancing Military Medicine. As a data manager, I work on multiple studies concerning global and domestic public health issues, ranging from cohort and incident studies to vaccine clinical trials. Dornsife has definitely prepared me to enter a career that is mostly multidisciplinary work. For the majority of the studies, the team are comprised of members from different education backgrounds and disciplines. Furthermore, Dornsife has taught me how to explain public health and epidemiologic concepts in a way that those without a public health background can understand. Lastly, my experience at Dornsife allowed me to sharpen my multitasking skills, as I often work to juggle 5 studies where I'm the lead manager for a majority of them. In the next 2 years, I hope to be pursuing a PhD in infectious disease epidemiology or MD PhD so I can become a physician scientist. Before starting my position at HJF, I worked as an HIV data analyst for Einstein Medical Center in Philadelphia. I worked with social workers and physicians to analyze patient and community engagement programs that targeted increased HIV and hepatitis C testing in the Philadelphia area. This position allowed me to identify and help strengthen weaknesses in the testing outreach and connection to care programs. Additionally, the monthly and quarterly generated reports helped identify demographic and transmission patterns within the city. My current position at HJF allows me to work on numerous infectious disease studies. As I work to support the emerging infectious disease branch in the military HIV research program, I am the lead data manager for the African HIV cohort study in multiple countries in Africa, the Lassa virus incident study in Nigeria, and a domestic SDI study. My work in each of these studies range from protocol development, data cleaning and management using SAS software, along with case report form and survey development. Being a data manager at HJF requires me to use my epidemiologic skills in analysis, study design, and ongoing management. My background in infectious diseases is especially important in study design because it allows me to quickly and efficiently work with study primary investigators and physicians. Often I am met with challenges in working with those who do not have a background or experience in data analysis when designing study materials. However, this job has shown me the importance of being well-rounded in multiple disciplines to ensure efficacy in completing assignments. My favorite memory at Dornsife was winning GSK student poster competition at a data analysis conference. I was able to submit my poster from my depth experience at Fox Chase Cancer Center. Lastly, I would like to share a bit of advice to students. My first would be to ensure that you finish your ILE and depth experience with deliverables that demonstrate your skill set. During my job interview and during my job search, I was able to use both of my projects to demonstrate my wide array of skills. My second bit of advice would be to learn and become a proficient with analytical or data visualization software before graduating, whether it be R, SAS, GIS, Stata, or SPSS. Having analytical software skills will make you more marketable in the job/fellowship search. My last bit of advice would be to pick professors' brains as much as possible if they share a common research interest. Professors love to share what they're currently working on and what they've worked on in the past. Additionally, they will always be available to help you as long as you ask them for help.
This slide highlights one of the recent Dornsife student experience related to the topic of infectious disease. In summer of 2020, a group of undergraduate students worked with a local hospital system to design a COVID-19 contact tracing program for their co-op placement. These students were trained in contact tracing activities and were able to develop components for a program through which medical students on rotation at the hospital will be able to implement this fall. Additionally, students have recently held placements at the Philadelphia Department of Public Health, the Hepatitis B Foundation, Prevention Point Philadelphia, and more. 2 organizations that are now accepting new volunteers are Action Wellness and Babashi, a local nonprofit that focuses on providing HIV/AIDS services. Thank you for viewing Module 3 of the 2020 Public Health Immersion program. As a reminder, Dornsife students who complete all 5 online modules and attend at least one of the synchronous sessions are eligible to receive a certificate of completion by completing the relevant evaluations. We welcome your feedback. The rest of these modules can be found on the Immersion program website. Stay tuned for information about the upcoming live virtual sessions that will allow students to explore these topics within the context of community-level disparities. These 3 sessions are population-focused, with panelist faculty on Black health, immigrant health, and LGBT health. We look forward to hearing about your experiences with the Immersion program at Dornsife broadly and as you continue in a career in public health.